So I was asked to just quickly give an update on some of the just the epidemiological aspects of the dual epidemic, I suppose, at this point. COVID obviously comes with its own complexities, multiple dimensions, which we won't go into at length. There's also consideration that we should give to how different these organisms and epidemics are. I'm not going to belabor this. I think just the interesting fact that we are essentially dealing with a disease that's as ancient as humankind, and the impact of the most recent human pathogen. We won't talk about the origin issues, but I think it's safe for us to say that both of these are here to stay. Even though we have better vaccine solutions for some, we need to deal with this reality that both of them will be with us into the future. On the COVID side, I couldn't resist to show you this picture, which Vitalis Lab produced. Alicia Arnott drew this picture, but it's a nice example of where the genomics capacity that's been developed at the New South Wales Reference Lab, essentially driven by routine TB whole genome sequencing, has put them in a very good position to track the COVID outbreak right from the start. And I know for people in Victoria, it's not a nice picture to look at the moment, but this essentially demonstrates the New South Wales experience. And what is amazing is, for the first time, we are able to give a complete overview of the introduction of various SARS-CoV strains into New South Wales and document their elimination. So you can see the phylogenetic tree on the left. Essentially, the y-axis is the frequency of strain occurrence and the x-axis is time. And you can see how with the first wave in New South Wales, at the beginning of the epidemic, we had the introduction of multiple strains coming through different ports, whether this was through our ships or coming from Iran or China, but we can track the time to elimination for each of those strains. And then the gray is essentially single strains which are imported all the time through our quarantine system. So they will obviously be the baseline. The second blob there, that's the introduction from Victoria at the time, the quarantine escape, and you can see how that circulated for a while. The dark green was a closely related variant that emerged, and all of that got eliminated over time. But we've got this exquisite ability to track things now, which TB in a sense enabled, and I'm sure this is the type of technology that will be with us into the future as well. I just briefly want to touch on this modeling analysis and some of the assumptions that were made at the time. We all know some of the limitations from modeling, but this was an important outcome which the TB partnership led and Stop TB partnership led, and it was really trying to capture what should we expect the impact from the COVID epidemic will be on TB globally. I'm not going to go through this in detail, but you can see that they've considered all the main impacts. They had to quantify what they thought those resulting numbers attached to the impacts would be. You can see in every instance they've accepted a negative impact, like a drop in case detection, a drop in treatment adherence, so increased drug resistance. None of our models to date have considered potentially the positive impacts of physical or social isolation or distancing, like we've discussed yesterday. But what the other, I suppose, limitation of this initial modeling was that it considered, like many people did at the time, the fact that COVID will be a once-off interruption. We'll have COVID lockdown, and then COVID lockdown will be gone, or the SARS virus would be gone. So all of this essentially modeled a single 3-month lockdown intervention and what its impact would be in time in increased cases, increased deaths, increased drug resistance. So this helped to, I suppose, galvanize people's awareness of the impact of COVID on TB control. I'm not going to dwell on the numbers. You would have seen most of those. But clearly, people have questioned how accurate those numbers were. They were some of the best predictions at the time. They raised awareness, but this is currently the best data that we have from WHO to be tracking what's happening in different countries. And just to show you, on average, there has been a significant drop in case detection. If you look at the 3 countries as exemplars where there were significant COVID interruptions, although this doesn't reflect the recent COVID outbreak in India, but you can see how there has been transient drops in case detection, especially in South Africa. Indonesia also had quite a significant drop, and this seems to be sustained. And this is real, and programs will have to deal with this. And I think the current interpretation is that it truly is cases that have gone undetected out there in the community. We don't have a lot of data as yet from people documenting, so what's the impact of this? Do we see increased transmission? Do we see case numbers rise again as case detection improves post-lockdown? So this will emerge, I think, in the next 2 to 3 years. This study published from Spain just showed some of the examples where we think this diagnostic access issue is a real issue, where you can see they compared pre-COVID, 3 months of a pre-COVID time period in 3 of their regions with 3 months of a post-COVID time period. And there was a suggestion that patients in the post-COVID period presented later with more advanced disease. So their cases that were diagnosed had more cavities, more bilateral lesions. And when they looked at the infection rate amongst household contacts of these cases, there were increased infection rates in the post-COVID period, also suggesting delayed diagnosis and increased transmission in the community. But this was the only some hard evidence I could find documenting some of these impacts at the moment. So I'm going to hand over to Warwick to just talk about the more biological aspects of the interaction and then to guide the discussion.
Thanks very much, Ben. And if we could just have, if you think about the interactions of COVID and TB, and I'm sure all of us here have thought about this in different contexts, we can think of the impact of concurrent TB on the clinical course of COVID, the impact of COVID on the course of current TB, and in particular latent TB, the effect on control programs, which is what Ben has discussed, and what lessons we could learn from COVID for TB control and TB research. Let me just... this is some data which is now starting to emerge. This was a meta-analysis, but really of 4 studies, and it was basically 2 of these studies that contributed most of the information, which showed that there was a significant increase in mortality in TB patients with a risk ratio of 2. And this was evident in different countries from around the world. This is, I think, a population study from South Africa, which was most revealing, where they looked at the mortality rates in about 3 million people in whom they also had matched COVID status. And the first and dramatic thing, this is from the Western Cape, was this dramatic effect of age on the adjusted hazard ratio for COVID death, so something which has been repeatedly shown, but is the most dramatic effect. The effect of diabetes, unequivocally, with a hazard ratio of 2 to 3. In this particular population, no effect from hypertension or chronic lung disease, and I'll come back to that in a moment. But you can see the effect of either a previous diagnosis of tuberculosis or a current diagnosis of tuberculosis, which had been microbiologically confirmed. So there was a definite increase in the hazard ratio for death, for a COVID-related death. And HIV positivity was associated with a similar effect. So both previous tuberculosis disease and active tuberculosis can have an impact on the clinical course of COVID. And the mechanisms of this broadly could be through two mechanisms. One is the simple but significant reduction in respiratory reserve, which is evident in some but not all forms of chronic lung disease. And this is the largest study recently reported from the United Kingdom, where they looked at the effect of pre-existing respiratory diseases, all forms of respiratory diseases except actually tuberculosis, on both hospitalisation and death. And you can see that chronic obstructive lung disease had an increased hazard ratio of death, as did interstitial lung disease, but asthma itself did not. The second mechanism, though, is through a heightened inflammatory response in the lung. And normally we don't express the H2 receptor on the surface of epithelial cells in the lower lung. It's expressed in the upper airways. Smokers, in fact, actually, smoking induces the expression of the receptor in the lower lung, as does other inflammatory conditions. So more rapid progression from upper airways infection to lower airways infection is possible. And of course, a heightened inflammatory response is associated with increased cytokine response. And so both of these mechanisms may be increasing the susceptibility of TB patients to poor outcomes. And this is actually shown in this study from the Philippines, where they mapped the outcomes in a cohort of 500 COVID-infected patients, where they were comparing those with and without tuberculosis. And you can see in the green line compared to the red line, both for outpatients and admitted patients with tuberculosis, there was an increased risk ratio for death, but also actually a longer time to recovery, shown in the bottom part of the slide, where there was delayed recovery of patients with tuberculosis from COVID. So what about the other way around? What is the effect of COVID on active tuberculosis and latent TB? And this is, in fact, much harder to disentangle because, as Ben was saying, the impact of reduced tuberculosis management, interrupted therapy, delayed diagnosis of new cases with progression, increased transmission. So all of these control factors could worsen TB. We know that moderate and severe COVID is associated with reduction in both CD4 and CD8 T cells and immune dysregulation. And this is shown in one of the early papers from hospitalised patients in New York, where you can actually show there's a marked lymphopenia and CD4 and even more of CD8 lymphopenia. In recovered patients, this shows evidence of improvement, but the rate of improvement at a population level we don't know. Is this lymphopenia sufficient to cause reactivation of latent TB disease? Could it cause increased progression during exposure to TB infection in populations? And if ever worked in an environment where there's both measles and TB, you're always struck by the impact of measles on the increased risk of TB in children, and whether we're going to see that in this context or not, we don't know. The only study which has actually looked at TB-specific immune responses is this very recent publication from Rob Wilkinson's group in Cape Town, where they compared immune responses in COVID patients, other hospitalised patients who didn't have COVID, and from a control group of 2018, which I know is not quite proper, but nevertheless in this context was helpful. And they looked at T-cell responses to SARS-CoV-2, a variety of proteins, and to M. tuberculosis. And the take-home messages are here on the right. They looked at progression of severity, and with increasing severity, the T-cell response to SARS-CoV-2 showed reduction in functional aspects as measured by polyfunctional cytokine production and increased progression. And interestingly, I won't go into all of the data, but the control subjects showed background evidence of cross-reactive T-cell responses. We've all been infected with coronaviruses, actually, to the seasonal coronaviruses. And in fact, in this population, they documented cross-reactive T-cell responses, but those, of course, are not protective. And even with seasonal coronaviruses, as Barclay and her group have shown, in infection studies in Britain, you need recurrent exposure to seasonal coronaviruses to be protected. The COVID patients had poorly functional T cells, and there was a reduction in T cell number. But from our point of view, this is the significant question: what was the effect on TB-specific T cells during COVID infection? And there was a reduction in the frequency of T cells, of TB-specific T cells, and these were more differentiated. And this is just shown here in a large population. In the green on the left, in a previous cohort, here of hospitalised patients, and here a significant reduction on this log scale of the frequency of reactive T cells. What does this mean? We really don't know as yet, but this in itself may also be predisposing to either a poor primary response or reactivation of TB. And the collection of this kind of data is of course, very difficult in the current situation. So, Ben, are you proposing we stay together rather than break into groups? We do need to have lunch in about 20-25 minutes, so that may be more efficient. And to start the discussion, Ben, over to you, Ben. Okay.
It's really an open discussion. I think those, Warwick, I suppose you could get that one slide, that final slide, but it was, maybe we can just start by asking people's opinions on what you think are research priorities in the TB COVID space, all across the translational spectrum, from basic science questions through to operational questions, and also questions in Australia, within our TB programs, but potentially in the sites where people work. I know, Greg, your group have already thought about some of this, but if there are any new questions from the emerging evidence, it's really to help us think through, just in the 20 minutes, if there are areas we should prioritize as a group or think about. Yeah, Bente.
I was just wondering about long COVID. You know, these 25 to 50% of people who report symptoms 3 to 6 months post infection. And do we know anything about that and potential TB risk, reactivation, BCG vaccination? We probably don't know anything yet, but it would be interesting to see whether those people who report long COVID have overall reduced immunity and increased risk of either reactivation or infection with TB. I don't know if anyone has, I haven't read anything about them, about long COVID and TB at all, or general infection. I don't know if anyone else has.
Oh, well, I guess I can report. second-hand findings. I guess most of the documentation of long COVID's been in an environment where there isn't a lot of TB. So that is the factor. All I can say is I know that from studies in Sydney, studies not in our laboratory, but others I know in Sydney have shown that there are ongoing immunological markers in people who have long COVID symptoms. Whether that results in immunodeficiency or heightened inflammation is unclear.
Maybe just on that point to ask if people think that there are any opportunities for COVID cohorts in some of our TB trial sites, or even keeping TB patients under longer observation. There's been a long standing question how we could capture post-TB treatment outcomes in TB patients. Obviously, TB programs are already often overwhelmed by the data they have to collect, but is there an added impetus now with COVID to say, can we track what happens with TB patients over a longer time period, and use COVID as a motivation?
Thanks, Ben. Would be terrific, of course, from genomics point of view, certainly chronic COVID infection, which has been recognized as a syndrome, increases the probability of this variant development, further mutations and potentially spread. But in practical terms, because I assume we're going to immunize a lot of people within chest clinics that are being treated, or during follow-up. This could be a cohort that potentially we can look for breakthrough infections of COVID, for example, whether there will be higher risk of breakthrough COVID infection in vaccinated individuals, and treatment outcomes affected by concurrent COVID infection. Just thinking aloud, really.
I guess there's a lot of white noise and all this, isn't there? There's going to be push and pull factors. Some things will increase the risk of TB. Some will decrease the risk of TB because of mask wearing, which you've alluded to. I guess one thing would be, if you have latent TB infection, does having COVID increase the risk of you progressing to active TB? And I guess if you had a cohort where you're watching people with LTBI, could you do antibody tests to see if they've developed neutralizing antibodies over the course of their, as a marker for COVID infection? Because most people who get COVID probably won't present for a swab. If you're in Vietnam, for example, some of those will be subclinical, but if you could do COVID antibody testing, and if those people had a positive antibody result suggesting they've had COVID infection, does that affect their risk of developing active TB? I don't know, I'm just trying to think through things that you could do with one extra test maybe.
Go, Steve. You can go with that one. I'll give this to Steve.
Hi, I'm Steve Corbett from Public Health at Westmead. Look, I'm interested in airborne infection, and I guess particularly hotel quarantine like everybody else. But I just wonder, is there anything from experience with TB using UV light, upper air UV light, either in rooms or in ventilation ducts? I know it's used in healthcare settings in some parts of the world, that might be germane to use in hotels or whatever other quarantine facilities are developed in the year to come.
Just a quick comment about the Vietnam setting and Andrew's comment around which cohorts we should be enrolling. We sort of have this window period now where people have not yet been vaccinated, therefore won't have an antibody response. Therefore, you can use serology as a test. Once populations have widespread vaccination, it's going to be harder to use that as a measure. And just a couple of quick comments in relation to Vietnam specifically. So, yeah, one of the difficulties. So we actually were funded to use our VQuin cohort to follow them up and see whether there was going to be an effective COVID on reactivation of latent TB, because it's a well-characterised prospective cohort. Our problem in Vietnam is they haven't had COVID enough to be able to cause widespread immunosuppression, and so we probably won't be able to go ahead with that. And in fact, we found in serology studies we've done now in 4 different locations that the case detection rate has been very high. There's been almost no missed cases, so to speak, because they've been very effective in quarantine. And Taz, my PhD student who's in the back row, might be able to comment further, but she's done some work looking at the National TB Program's data in Vietnam. And I don't know, Taz, whether you want to make some comments about what you found.
Thanks, Greg. So I guess in Vietnam, what we have found is that the impact of COVID has been relatively modest, which has been reassuring, and I guess it's reinforced the idea that if you control COVID, you're also able to control the adverse effects of COVID as well. So the drop of MDR notifications has only been about 1% over the year, and the drop in overall TB notifications have been 8% over the year. But the interesting thing is that during the outbreaks, so in April there was an outbreak of COVID in Vietnam, and then again there was another outbreak in August. And if you look at the cities in which there were outbreaks, or the locations in which there were outbreaks, in those settings, the drop in TB notifications were much more substantial. So there was a 30% drop. So nationally, there was a 30% drop in TB notifications in April. And then in Da Nang and Quang Nam, where there were outbreaks of COVID in August, the drop in TB notifications were up to 70%, so they were quite substantial in August and September. But yeah, I guess now there is a more substantial outbreak of COVID in Vietnam compared to in previous months in 2020. So I guess it will be interesting to see what the long-term effects will be. And I guess looking at 12 months of data is not sufficient. We need the true impact will be going forward in the years to come.
Just before Steve, and for Steve to comment, it would seem to me the biggest at-risk population, apart from delay in diagnosis in adults, will be in children. So if you could be actually monitoring infection rates and progression to disease in children subsequent to COVID over the 12 months, or that may actually be revealing as to whether the critical issue around whether COVID does predispose to increased progression to tuberculosis. So is it actually totally a control factor, and therefore you just need to get the control program, or is there some underlying biological impact? So Steve, is that measurable?
Yes, of course, I think it is, but yeah, it could be challenging, of course, but I think what you're alluding to is that particularly in young children, rates of infection can change over time as a reflection of reduction in TB control or improvement, such as guys shown in Vietnam, I guess. I just wanted to, the thing that I've been thinking about, a couple of things, is more around opportunities for decentralization. One in terms of, and I'm not really sure, but the need to help, in TB I think we've been for a long time recognising the need to strengthen services and decentralise services, whether that's for detection and treatment of disease, even including MDR TB, more from the facility towards the community, and certainly the success of preventive treatment and contact screening and whatever is seen to be much better at a community, more decentralised level than at a facility level. So given all the restrictions associated with COVID, how do we support, because that's also important for COVID as well in terms of strengthening health services at different levels, how do we support that? And the other issue is in terms of strengthening research done in more TB endemic settings, given that in the sort of north-south relationship, if you like, there's less opportunity for travel in countries, etc., like that. But how do we support strengthening of those, or that capacity building for research in countries in the region? This is an opportunity, perhaps.
If I could add some comments and questions from people online. We have a comment from Tim Gray. He would like to comment that we do have antibody assays available that can identify natural COVID infection versus post-vaccination. Just circling back to what Ray was saying earlier. And we have a question from Katerina Aronica. In terms of basic science priorities, we urgently need animal models of COVID and TB co-infections. It is a major challenge for our group at University Queensland to get IBC approval for using 2 respiratory PC3 pathogens in the same facility. Is anyone in the audience aware of research groups that have obtained approval for such studies in Australia?
Warwick, that you've gone through all the centenary issues on approvals. Do you have 2 PC3 agents?
Well, I guess we're in the process of that. In fact, actually, the animal models, it's interesting, you know, as a person who's used animal models in research, they're useful in some areas and not in other areas. But in particular with COVID, this is unpublished data from Phil Hansborough's group, but Phil and Matt Johansson have actually shown a gender-dependent effect, and in fact, if you reduce the dose of COVID, you can actually get female mice that survive, whereas less of the male mice do. And Jamie will also present some data later today, I think, which actually shows the power of the animal model in these circumstances. So we do have a model of low-dose COVID in which we have mice which recover. So that is what you need if you're going to be able to show what makes COVID worse, whether it's TB or diabetes or other things.
But the problem of possible co-infection, would that not be an issue here for the Queensland people to use you as an example?
Well, you have to separate the two issues of processes. In fact, actually, the procedures that you follow with COVID are much more intense than you follow with TB, and so that it's quite practical to be able to do that. Yeah. Yeah.
Yeah, I think Warwick, we know one of the issues is also the difficulty in getting approval for these experiments, and I think it's an issue of those individuals in a position to help us move this forward, not appreciating they clearly must appreciate the problem of COVID, but the red tape seems to be even greater in a period of a pandemic when you want to do research on the pandemic pathogens. So I think that's a big concern. I mean, because I think that clearly there must be priority to move certain things forward, and not actually have to come back a step and jump through a remarkable number of hoops when, you know, groups such as Warwick and us who work together have been doing these sort of experiments for decades. Warwick, unfortunately, sorry to say that, but so for both of us. So I think that's been a real burden. It's taken us months to get approval for really simplistic things to do. You know, running a sample on a flow cytometer. We have to fix samples 1,700 times just to be able to prove that. I mean, it's just so it's a real impediment, and it's also localised. Some other places, I think, have been able to make that case much better than I think
So
we
in
make
some
the case,
places
but-
you get something approved, and but you can't get what's approved in other places, and in the other place they have something approved that you can't approve. I hope everybody in this room has been immunised, as I won't ask for a show of hands, but we all should be, and encouraging people to be immunised reduces, in a sense, the sometimes disproportionate concern that is shown when you are following all procedures. So I know Katarina's having problems, and I feel.
Yeah. Now, I just wanted to ask maybe on the if there's any qualitative, we still have Angela, but the stigma issues. It was interesting to see that in a number of countries, people seem to have a far greater fear, like in Indonesia, of being identified as a possible COVID case than a TB case. Is there any stigma research opportunities around this, and could we help to reduce TB stigma and even the stigma of mask wearing, using the COVID experience in a positive way in that regard?
So thanks, Ben. In Papua New Guinea, certainly there's lots of evidence of stigma, and including people having to be relocated to different houses after they've been diagnosed in the early days. But in fact, now what we're seeing is that people are not caring about COVID at all in most of the highlands and Port Moresby, and there's not a lot of mask wearing, and there's certainly no social distancing. But we are about to start a study that looks at stigma. We're also looking at some social media research around miscommunication or misinformation that's going around. Of course, the issue about guinea pigs and Christianity and being genetically modified, of course, is going rampant on social media in Papua New Guinea. I think one of the things that's interesting is not so much the biomedical things, but some of the social and the structural things that are going around. I know it's not necessarily TB, but we've got evidence in Papua New Guinea where to be allowed into the hospital premises, you have to show your medical record. And so that's been inhibitive of people living with HIV, for example, to go and get their antiretroviral therapy. So we've got some work that includes the Burnett as well, which we are going to look at not just the impacts of COVID on infectious disease services, so we're using HIV and TB as our case studies, but also primary health care. So we're looking at maternal health and child immunisation, and also outreach, what do you call it? Yeah, outreach clinics for malaria testing, but also looking at the opportunities that COVID's provided to local areas to actually mitigate against the impacts. So we're doing some work there, which will be in about 6 sites throughout the country.
Just to add some qualitative findings from the Vietnam setting. So Sarah Bernays, who's a qualitative researcher from the University of Sydney, has been working with us and the National Hospital for Tropical Diseases and others in Vietnam to look at stigma relating to COVID, and she's also done work in the past looking at stigma relating to TB as well. And you know, the story that she tells from the in-depth interviews that were done is sort of a complex one, because on the one hand, in infections like TB, we want to destigmatise TB, right? Because we want to avoid victim blaming and so on. But in a disease like COVID, there needs to be a degree of stigma, otherwise people don't wear masks and take precautions. And so there's sort of this sweet spot. There's this sweet spot, yeah. Well, I think the disease itself needs to be recognised as serious, and people who have the disease need to recognise that they need to take precautions. And there's a healthy, cultural response to infection, which sometimes if you go too far one way or too far the other way, can have harmful effects on patients or can have harmful effects on the community. So that was interesting. Her research also showed that social media, like you're saying, was in some cases a highly punitive environment for people who had COVID, and there were some high-profile cases in Vietnam where everybody sort of piled on these people who were sometimes named and shown in photos and so on social media for having the disease when they'd returned from overseas, for example, which was very counterproductive. And so what she's done is she's developed this video where she's tried to sort of reach this balance of understanding the importance of being concerned, but also of not leading to a counterproductive public health response by driving people's care seeking underground because they don't want to be identified. And so I think that there's a lot of very helpful ways in which qualitative research can then go that next step and then inform the public health interventions and the nature of the messaging around that.
I guess a question for Steve and Greg and others would be, is it likely, if there is more advanced disease, if there is a higher risk of transmission to children during this period of the impact of COVID on control programs, will that be measurable by detecting more contacts who progress to disease? In other words, should there be greater emphasis on contact tracing? And I guess people have learned about contact tracing, at least here because of COVID, a greater emphasis of contact tracing in the post-COVID period because you actually may get a higher frequency of cases. It's a self-evident question, but how do you do that?
Well, I think that Spanish study at least provides some proof of concept that it's something to be concerned about, that there is evidence of potentially increased transmission within households. That in many endemic settings, child TB diagnosis remains a major limitation. So you can't really use the disease signal in children as an important signal because so many kids are misdiagnosed. But in Da Nang, for instance, I know that they've had at least an increased awareness. There's the greatest number of pediatric TB cases they've ever had in the hospital. They have now in this post-COVID lockdown period. But Steve, you may have comments on how to measure this more systematically.
No, I agree with Ben. The challenge, of course, is always the low numbers of bacteriologically confirmed TB in kids. Makes that measurement always questionable, I guess. Whereas prevalence of infection or changes in that is easier to perhaps monitor. But I was just this morning describing a couple of children we've recently seen in Melbourne with severe disseminated disease who were only really exposed because of COVID. And that was because of situations that changed where grandparents stayed in those households for much, much longer periods of time while they developed their TB and were in those households. And then we had the 2-month-old and the whatever come in and with their very severe disseminated CNS TB. So, it's not, and that's in Melbourne. So, but that's N equals 2, but you know what I mean.
In terms of opportunity, I wonder if there's a chance to take advantage of some of the contact tracing apps that have been really well picked up in a lot of countries. And I think people are not as concerned about privacy when they're realizing the personal benefit. And so they could potentially be adapted to some TB programs or more widely infectious diseases.
Just to very briefly reflecting on comments from Stephen, others, I think we're converging on synergies between these two diseases and potential to utilize capacity that CRE and others have built for TB in learning about COVID and the impact of COVID on TB and the other way around. And in a way, you can treat it, TB population as a sentinel and in this setting. And I think Ben made a point that because we developed genomics for TB and Salmonella tracing, we've been in a very good position to immediately apply it to COVID control. And this is just an example how capacity can be leveraged. From practical point of view, from disease control point of view, and from basic science point of view, that I think there are essentially huge opportunities, whatever box you tick.
Yeah. Now, one thing I was wondering when you mentioned Vitali, just a final comment, was on the, in India, for instance, where there's been a lot of social attention on the increase in severe fungal disease with excessive steroid use. But can you imagine the potential impact of that excessive steroid use on TB risk? And no one is, to my mind, has captured that. I'm not sure if there's other countries where excessive steroid use as a last resort is as widespread as in India. Is that used in Vietnam as a treatment option? Because it seems like in India people were getting steroids off the street in high numbers because that was considered to be the only treatment option available, for which there was evidence. Yeah.